I'm Prashant Kedia, Medical Director of Interventional Endoscopy at Methodist Dallas Medical Center. I wanted to talk to you about an interesting case that we did using some very new endoscopic techniques to help a patient out with a couple of different problems that they were having. So the techniques we're going to be discussing today involve third space endoscopy. Third space endoscopy is one of the newest areas of endoscopic innovation, which allow an endoscopist to tunnel between the layers of the GI tract, which is a relatively new concept. So when we do endoscopy conventionally, most people think about a camera going inside the mouth or going from the rectum and looking inside the lumen of the GI tract and doing interventions or diagnostics from inside the lumen. But in the past decade or so, endoscopists have been able to develop a technique where not only are they looking inside the lumen, but they actually can tunnel between the layers of the lumen or of the wall of the GI tract. And this has opened up a whole new world of opportunities and possibilities in what we can achieve with an endoscope. Some of the techniques that people are using to address different types of diseases using third space endoscopy includes the removal of tumors or cancerous or neoplastic lesions, and also the treatment of a lot of different motility disorders of the GI tract, in which there are areas of muscle in the GI tract which are causing obstructive processes or inability for food and liquid passage, and by using an endoscope to access those muscles and cut the muscles, we can actually improve motility problems in patients. So this case that we actually did was very interesting because we had a relatively young patient who presented with two problems. They had an endoscopy that showed that not only did they have a small cancer in the bottom of the esophagus, but they also had a motility disorder in the top of the esophagus called a Zenker's diverticulum, which was a small outpouching of the esophagus in the upper esophagus, catching food and liquid and pills and things like that, making it hard to swallow. So the patient was having swallowing problems, and more importantly, he also had a new cancer diagnosis in the bottom of the esophagus. Luckily, his cancer was early in diagnosis, and there was not a large lesion there, and it was not invasive through the esophageal wall. But it obviously needed to be dealt with and removed from his body. So we offered him two different techniques, endoscopic techniques, one to address each of the issues that he was having. The first one is called endoscopic submucosal dissection. This is a technique where we use third space endoscopy and tunnel underneath the tumor in the esophagus. We literally tunnel underneath the entire tumor and then cut it out from underneath in one entire specimen. So it's kind of what like a surgeon would do in terms of removing a cancer, in which they're trying to get negative margins around a tumor so that you can make sure that there's a complete cure. And by using endoscopic submucosal dissection and getting a large plane of dissection around the tumor endoscopically, we're using very specific surgical or microsurgical tools through our endoscope, we can actually remove these tumors in one big piece and give it to our pathology colleagues to assure that these cancers are cured. And indeed, we were able to remove his tumor completely, which was a great thing for the patient. And then secondly, and that procedure only took probably about an hour and a half to do, and the patient actually went home the same day as his tumor removal without any need for hospitalization. So he was very, very happy to be cured of cancer. After we removed his cancer, we made sure to bring him back to treat that Zenker's diverticulum, which was giving him trouble swallowing in general. And we were able to do a specific new technique called a Z-poem, or a Zenker's per-oral endoscopic myotomy. This is a endoscopic third space technique where we tunnel down the esophagus and identify a high pressure muscle called a cricopharyngeal bar in the upper esophagus that results in high pressure zones and bowing out of the esophagus, creating these Zenker pouches. And by tunneling between the layers and identifying that muscle, we can actually cut the muscle down to its base, remove the high pressure zone, and allow for the Zenkers to kind of resolve itself. So that was another less than hour and a half procedure that we did for the patient that restored his swallowing function and gave him back a good quality of life so that he can start eating normally and eat normal things without a feeling of food getting stuck in his throat. So these otherwise would have been two surgical procedures and quite large surgical procedures that a patient would have had to undergone to treat these disorders. But with our new techniques endoscopically, we can we can fix them in outpatient procedures. So we're very happy to be able to offer these things, and we're very excited about where endoscopy is going in the future and what we're able to offer patients in a minimally invasive fashion. We hope to continue doing this, and it's important for both primary care doctors, gastroenterologists, surgeons, various different specialties to know what's achievable now with an endoscope in the modern era, and we're happy to be at the forefront. So, thank you.